The following is a brief segment from our hour-long PL Voices Clinical Recommendations webinar held on July 17, 2013, and discusses management of COPD. This one is led by session moderator and PL editor Dr. Sherri Boehringer. You'll also hear the voices of Dr. Craig Williams and Dr. Antonio Anzueto, contributing author to the Gold Guidelines for Management of COPD.
Where we're going to start is with the first section on short courses of oral steroids for acute exacerbations. And the reason why we're writing about this is because the standard of care and what guidelines say is to use short courses for 10 to 14 days, but there's a recent study suggesting that 5 days of prednisone is okay for an acute exacerbation. And I should clarify that by saying 5 days of oral prednisone. So what are your thoughts? We make a recommendation in our article saying give oral prednisone 40 milligrams a day for 5 days. Do you agree with that recommendation for acute exacerbations?
I do agree 100%. The other important message that we're giving there is that giving this patient very high dose of steroids is not appropriate. Very often these patients with COPD exacerbation, especially if they're hospitalized, they get a gram of Solumetrol of 250 of Solumetrol every 4 to 6 hours IV, and that is not appropriate. We do have studies that show that the lowest dose and the shorter duration of time is the best way to go.
If anyone's still doing that, it might be worth mentioning. I mean, we haven't done that for quite a while, but if that's still going on.
Well, I think it is.
Well, but I think was our guest even talking about the higher dose? I mean, the old days was like 125 Q6 for 3 days, and that hopefully no one's still doing those super doses.
Maybe not the super doses, but they're still doing it.
Yeah, I mean, maybe that's worth throwing in here. If this were focusing on the steroids, that might be worth noting that hopefully no one's giving 500 milligrams of Solumetrol a day anymore to their COPD exacerbations.
Yeah, so I do think
there is people giving an IV, especially in hospitalized patients, and when patients are sicker, are the ones that like to do it, and those are the patients who are more likely to get side effects.
Interesting.
That actually brings us to our next question and the next area of the article, which talks about a new combo inhaler called Brio-Ellipta that combines a once-daily steroid and long-acting beta agonist. So I don't want to talk too much about Brio-Ellipta, but what I do want to talk about is the place in therapy of the inhaled steroids. So I think that the way the guidelines outline it is inhaled steroids, they're not first-line options for COPD. Usually patients are going to be on long-acting bronchodilator or long-acting anticholinergic, and it's at that point that the inhaled steroids are added if necessary. Do you agree with that, Dr. Anzueto, as far as place in therapy of those?
Yes, what we have in the literature today are 2 points. One, in patients who are more severe, if it wants less than 50%, they would benefit from inhaled corticosteroids, as well as patients who have frequent exacerbations regardless of the severity of the lung function. We are seeing more and more literature emerging of this we call overlap syndrome. So what do you call a 55-year-old to happen to smoke and have atopia and have asthma? So that person has clearly an asthma, a very significant asthmatic component. And this overlap syndrome, the ICS should also be part of their therapy. So the 3 conditions are going to be severity of disease, frequent exacerbations, and this group of patients who are asthma COPD.
Okay, that makes sense. So you're obviously going to use the inhaled steroid sooner if you suspect an asthmatic component, right?
Yes.
Okay.
But the pivotal therapy is bronchodilator, and if so just initial therapy, you don't have any of these components, it should be a long-acting bronchodilator.
And another thing that's coming up in the literature is about the use of beta blockers in COPD. And I think most of us were taught that beta blockers can worsen COPD, but there's actually some new studies suggesting that they improve outcomes in COPD patients. So we're a little bit more willing to use them in COPD patients. So I guess my question is, do you, Dr. Anzueto, and actually Craig, you can jump into here, do you feel more comfortable using beta blockers in patients with COPD?
We have in our panel cardiologists, and this is one of these issues that is very interesting. From the cardiologist point of view, we should say we should use beta blockers. From the pulmonary point of view, at one point, no, because they produce more bronchospasm. I think as a pulmonologist, we miss the boat. And we miss the fact, and we are understanding now, and that was one of the areas that Cole has brought a couple years ago, is that COPD is not a disease of the lung alone. This patient has significant comorbidities, significant cardiac disease, And as a consequence of that, we need to optimize their cardiovascular therapy. And being beta blockers is one of the pivotal therapies in patients who do have any kind of coronary artery disease. So the recommendations, and we now have observation as well as interventional trials that have clearly demonstrated that when patients are on beta blockers, they have less exacerbations and they actually may live longer. So beta blockers should be part of the treatment of this disease.
One thing I'll say, Sherri, I think you kind of struck the balance pretty well, that we know if you have a cardiac indication for a beta blocker that outcomes are improved from a cardiac standpoint whether or not you have COPD. So we should not shy away from a good cardiac indication. Maybe I'm just not familiar enough with the new data, but using beta blockers to improve COPD outcomes would be a bit of a shift from my way of thinking.
Yeah, I think we're not ready to say that yet.
No, it does not improve the COPD outcomes. It's recognizing the fact that patients with COPD have significant cardiac comorbidity.
Okay, right.
And what you're doing, you're improving the cardiovascular aspect, and the myth that patients with COPD given beta blockers are going to get more bronchospasm, are going to get worse. That is not true. All the new cardioselective beta blockers have been shown to be effective and safe in COPD.
Thank you for listening to this segment from our PL Voices Clinical Recommendations webinar series.